Yeah. Since I had time to unfortunately prepare a little bit, and I just kind of dropped this in Eric's lap without emailing him. Let me just pull up a slide or two. So since you'll cover on like day 2 on that Saturday, biomechanics of the lumbar spine. I was thinking of just starting with kind of a quick review of just flexion, extension, rotation, side bending, what we tend to see with these mechanics, how we look at them and how we describe them.
Yeah, I mean, from a biomechanical perspective, it's not terribly complicated for the lumbar spine. Flexion is coupled with an anterior translation, extension with a posterior translation. Side bending, same sort of deal. You side bend left, you're going to get a left translation. Side bend right, you're going to get a right translation. But what we'll see in the more complicated one is usually rotation, just because the lumbar spine is not really designed to rotate. And we've talked about this a ton in the courses. The neural arch and all the long ligaments, and the disc itself, the orientation of the fibers of the annulus really are designed to resist rotations. So what we'll see is, and what we should see is, if I rotate right, we should get a left translation of the lumbar segment, right? And that typically is what should occur. Problem becomes when you start to limit the amount of rotation that's available, particularly through the TL junction, which is, again, why we spend so much time working on this, on the TL junction, is that you'll end up hyper rotating the lumbar spine to get these impacts of the facet joints, and then all of a sudden you'll start having these secondary axes of movement that'll start occurring, right? So you'll start getting, instead of it pivoting around the anterior portion of the disc, which is really where it should pivot, right, kind of toward the front third is what I would call it, of the vertebral body, is really where that axis should be. But as soon as that facet joint impacts on that opposite side, you're gonna start pivoting around that, and now the axis is essentially swinging around that posterior element, and that's where a lot of those problems come in. But for the most part, the cardinal plane movements, flexion, extension, and 2 side bendings, are pretty simple. The vertebral body should follow the movement that you're producing.
Yeah, so I guess the problem you run into here is you start to get into your degenerative models. That's kind of the person we're going to see, maybe like a stage 2 degenerative model where the disc starts to collapse a bit on itself, and where Eric's talking about is that there's an axis of rotation through the disc, which he's talking about in that anterior 2/3 portion, where is the pivot point of the disc, where the axis of rotation, a healthy disc, is somewhat fixed in that spot. But when the disc starts to break down and you start to get annular tears and fissures, and that happens, what it is that axis of rotation starts to pivot around and move around within that area. So as you get this translating axis of rotation, that's what creates that kind of instability, as it were, within that segment. And now your flexion axis or your extension axis, your axis then becomes off. And I think we talked about that a little bit last week, as far as the different, the Kirkcaldy and Willis stages of degenerative changes, and that middle zone, that middle stage being that instability phase, or that expanded neutral zone, because of these issues, because you've lost disc height or the collapse.
Yeah, and the disc height collapse is really problematic too, because it's a natural component of aging. Typically, by the time people hit about 30 years old, you're starting to see these things become much more fibrous. They have less water content. They're stiffer. But you're still able to tension the fibers of the annulus, right? And I can't remember who the researcher was that kind of accidentally discovered this, but it turns out that the tension, this act of tensioning the fibers of the annulus, actually has a reflexive mechanism to trigger the multifidi muscles to turn on. And essentially, this person, I think it was a surgeon, was going through and doing some sort of lumbar fusion or something like that, and they started poking around at some things and started noticing this reactivity of the lumbar multifidi, especially the deep layers, that single segmental layers, that 4th deepest layer of the multifidi, were kicking in. They were triggered by that pressure on the annulus. So if you start thinking about, all of a sudden you have this annular height starts to diminish because of not what we consider a degenerative change, but some sort of deterioration of that tissue, right? So this is a pathological process, not the normal process of aging. you start to lose that tension on those annular fibers, right? So you start getting these movements that'll occur before you're able to tension those annular fibers. And all of a sudden that means less reactive contraction of the multifidi to help control these movements, right? To help fine tune these movements and help protect against banging against these inert structures, these inert barriers that really shouldn't be stressed. Really we should be hitting the multifidi first, and that should be what our barrier to movement is, as opposed to running into some of these ligamentous structures or some of the, the articular structures like the facets and things like that. So you can see how this starts to spiral things, because now all of a sudden you're banging into these inert structures, they start to break down, and then that further destabilizes the segment and just makes even more of this kind of play that you develop in between these two segments even more pronounced. And so it just further diminishes the recruitment of the multifidi, and that's when you start seeing this, this atrophy, right? I think it was Earl Pettman used to tell me to think about the multifidi is trying to fill this osteoligamentous tube, right? So if we have the articular pillars right here, so spinous process would be here, transverse process would be out here, and then we have the overlying thoracolumbar fascia. There's this tube that runs vertically up and down our spine that should be filled with muscle tissue, the cross-sectional area of the multifidi muscle tissue. And as that atrophies, it doesn't fill that tube anymore. Right, so contraction of those muscle fibers should press against the bone and should press against the thoracolumbar fascia to tension these structures and make the spine much more rigid. But unfortunately, if you start to have atrophy and it no longer fills in that space adequately, you can't solidify the spine for things like lifting or things like bending forward, that sort of nature, where you really need the spine to become much more of a solid lever. So it's a self-perpetuating problem when these things start occurring.
Yeah, that's why I talk about people with these chronic and subacute phases need almost hypertrophy, repeated training. Going beyond bird dogs and other things that are more than motor control exercises, they tend not to create the hypertrophy to create that muscle mass that Eric just talked about.
Yeah.
So
at a certain point, you have to have it.
Yeah, so at that later phase training, and that's what happens to us sometimes. We get these people well, they feel better, we get them activated, but they don't make it into that phase of hypertrophy where they create that volume effect.
Yep.
And again, it's interesting too. It's a double-edged thing. It's like you have pain in the annulus or those outer fibers, like the injected pig's discs, and basically when you do that, it inhibits the deep multifidi as well. So you could have this lack of tension do it. You could have pain as an inhibitor as well, as we all are kind of aware of. So with this, you'd have that expanded neutral zone inflection that we talked about last week. If you get this tissue breakdown, this decreased disc height, now all of a sudden you have the expanded neutral zone and the wear on the joint.
Yeah, and it can go in any direction, right? I mean, you could have a leg length, functional leg length issue on, say, the right side, and you're hypermobilizing into extension, right? And so all of a sudden now the moment is going posteriorly instead of anteriorly. So see that sort of stuff all the time. But biomechanically, essentially the biomechanics, the problem is that you need to know what the proper mechanics are, so that when you start seeing improper biomechanical movements, you can say, oh, well, this is not right and this needs to change, right? And so, what set this off? How did we get here? That's going to be our etiology, right? Where did this stress come from that this has started developing? And then, figure out a way to fix that sort of thing, so then you can rehab the movement to the direction that you need it to be going.
Yeah, and I'll post some of these slides in here where we'll have some of the other things of what restricts these motions. Like if you have the, anterior, kind of talking about sagittal rotation from one of them is what structures to what degree limit forward flexion. And that's some of the data's in there. It's helpful to kind of see, just to understand, okay, what structures are truly limiting it. But it's probably doesn't merit per se enough of an in-depth discussion to have, just to know that, okay, you have tensioning of the facet joint capsules contributes to a lot of it, sacrospinous, interspinous ligaments, ligamentum flavum, intervertebral discs. These are all structures which will limit that forward motion, that anterior translation stress, as well as that facet joints are probably the number one limiter of anterior stress in forward flexion. Would you agree, Eric?
Completely.
Yeah. So in the lumbar spine, imagine that they are more like J-shaped. So they're kind of cups that sit on each other. So that also further restricts in the abut. And something you'll find too is that a large number of people have facet joints that vary in their angulation. It's common to have one side, which may be this nice J-shaped, but the other side could be angled at 45 degrees, or the joint could be facing in the straight sagittal plane, which would allow for more of a rotary instability on one side. And so when you're doing some of your rotary instability tests and some of these assessments, meaning what you may end up finding here is it may be a degenerative segment that's broken down. But I also think too, it's like, okay, it's not uncommon to have two different facet joint angles at L5S1. And you could be seeing this person with this anatomically, rotary, moment that can occur. An extension, Eric, tell me a little bit about extension while I find a slide.
Sorry, say that again. I was typing something in the chat.
Oh, no, go ahead. Answer the question. No, I'll go on extension. I found my slide because, yeah, I was going to go over there and check next. So if you don't mind grabbing them real quick. Yeah, there's also an article, Mark, in the lumbar module section 1 in the fellowship reading on hypertrophy of multifidi and different things and different ways to do it. We'll hit up Tanner Newberger probably at the end of this too. I'm sure he has a thought or 5 on this. So if you think about extension, extension is really the reverse of flexion. There's going to be a posterior translation moment, if we're talking about there. You have the superior facet coming back on the inferior facet. And, you get to the end range of this. This can be limited by the impaction of the inferior articular pillar on the lamina of the inferior vertebrae. And again, it's the same thing Eric had talked about with, rotation is that, again, if this is hypermobile or there's increased mobility here, it can create an altered axis of rotation in this position as well. Hyperextension. And again, facet orientation also comes into play. That person who has that hinging instability in the lumbar spine. You can think about, where does this moment create? Do I have an altered axis or altered axis of the facet joint? Or have I created a rotational instability where this person can hinge through, let's say the L4, L5 segment is probably a common one, where you're going to see this hinge point.
Oh, yeah. And we have to consider, again, I always go back to the anatomy of it, but we have to consider the anatomy of the facets, right? So if you're looking at it from a superior view, right, you're looking straight down the spine at these facets. The facets are not shaped like this. They're not straight up and down. They're hooked, right? So we either call them like a C shape or an L shape, something like that. So when the superior articular facet comes, the inferior articular facet of the superior vertebra, right? So this would be L4 coming down on L5. What can happen is you can actually impact that lower facet. And what it'll do is it'll hinge you backwards like that, right? So you get this, it'll come down and back, and then that will impact and it'll hinge things backward like that. So you develop these sort of linear instabilities, right? We've talked about the idea of instability being these non-physiologic movements, more of these shearing type movements that'll occur versus a hypermobility is more angular. Similar to like a recurvatum in the knee, right? It's not the same as an anterior instability when you lose the ACL. But in the spine, that's not necessarily the case. So you can actually have these things where they impact there and it'll create this hinging movement. And again, it's the exact same thing as what we were talking about before with the facet joints. All of a sudden, that axis of movement is no longer through the posterior element of the disc there, where it should just be the sagittal plane rotation. Now we're getting this hinging movement as this thing is pivoting around that impact point on that facet joint. So again, I mean, once it breaks down to that point and you start developing that biomechanical fault, it's just going to perpetuate the problem and make it worse, right? Because now all of a sudden you're getting this linear shear, posterior linear shear that's coming across that intersegmental space, and that stuff will break down pretty quick. Yeah. Posterior instabilities are significantly worse than anterior instabilities in most cases.
Okay. Yeah. And, this presents differently in different people. So if it's a 65-year-old man who's getting pain, it's focal on extension, there's probably a significant breakdown there. There's probably bony spurring occurring all around this facet joint. And it could be an abutment of that bony spur and that tissue going on. And in, that's okay, it's the 16-year-old or 17-year-old male, let's say lacrosse player, who has a rotary pattern where he's impacting in an extension moment here. You can see where, this can lead to stress fractures as you're levering through this in the lower back, but also an impaction syndrome where, you can see swelling in that because, as that facet joint is impacting on the lower vertebrae, you're creating stress maybe on the upper vertebrae, but you also have impaction and irritation from there. So you may do a biomechanical exam on this person and you don't find them subluxed. You may find an expanded neutral zone, maybe going into extension possibly, but not having the negative, pivum and pavum, doesn't necessarily tell me, oh, there's nothing there. But it now tells me, is I got motor control or do I have an impaction or something going on that's stressing the structure? And I got to think through it. So I don't move on from the biomechanical. Getting a normal end feel or a slightly expanded end feel there strengthens my idea that it's a biomechanical problem. And you really need to take a close look at the motion they're doing, how they're doing it, where the forces are loading and coming through. Because chances are, when you look at them in sport, they'll look pretty normal, but there's that moment where they linger too long in a phase, which then creates this impaction. Can you think of where you see this, Eric?
Oh yeah. You think of any athlete that has to do something in extension significantly. Probably the most obvious one to me would be a ballerina, right? Mm-hmm. So somebody that has to have, real mobile hips and a real mobile lumbar spine, right? And then really stiff ankles. This is one of those problems that that type of athlete will get. You'll see it a lot in gymnasts. You'll see it a lot in like figure skaters, things like that, where they're doing these sort of high speed extension moments. You probably even see it in some track athletes, I would imagine. Somebody that's like we talked about, this is a while back now, but the high jumper or the pole vaulter, those sort of athletes where they have to create these hyperextension moments to get over these bars. So there's all kinds of examples out there for this stuff.
I've seen it running. I've seen it with soccer. It's usually a rotary problem where they're not there. It usually starts off as a rotary problem too, because they're driving the rotation through the lumbar spine versus the hip or the foot position.
Correct. In the rotary is going to be the most common, I think, by far.
Yeah. That's kind of what you talked about before about, in spine biomechanics and rotation. And this kind of illustrates the facet joints, and you can see how they're set up to kind of block rotation. So as you get about, depending who you read, 3 to 4 degrees of rotation through the facet joint before you compress the cartilage. I think once you get past there, then the capsule starts to fail pretty quickly.
Yeah.
So this is a fairly restrained system. Rotation. So if you have an abnormal rotary moment or excessive rotary force coming in here, it doesn't take much of a rotary moment with repetition to start to break down this segment.
Yeah. And when you think about any type of athletic activity, they're almost all rotational, right? Running is a rotational activity. Swinging sports, things like baseball, softball, golf, hockey, all these sort of sports are all rotation based. So it's really hard to find something where this is not going to be potentially a problem.
Yeah, here you get, certainly bony spurring is a common one on the impacting one, but they're also often talk about the joint capsule on the opposite side that's getting lengthened. So you may have bony spurring and compression and a restricted articular feel on the side that's constantly being impacted, but the opposite side, you can see just as many dysfunctions, expanded neutral zone, even spurring from the capsule pole on it. You can get some changes on either side. One's just occurring because of excessive compression. The other one is because it's hypermobile. It's accommodating to the stresses there. So you see changes on both sides of this. So, many times what you may find is that the restricted side isn't your more painful side. It would be the side that it feels like it's moving more. It's more unstable. That's your pain generator.
Yeah, outside of where you're actually impacting something with like a bony spur, where you're kind of digging something into that subchondral bone, most of the time the painful structure is going to be the one that's still moving. The one that doesn't move enough to produce any pain. It's too stiff. Yeah, this is exactly what I was talking about before. That bottom right. image.
Yeah, so it's on even there, very large forces, are really needed to strain the disc beyond 3 degrees. But again, once you start getting in those degenerative phases, you lose disc height, get slackening off of the ligaments. You now can have this excessive translation, or this altered axis of rotation of motion through the disc, because it's no longer inflated by the nucleus. So it takes the tension out of it, and losing the tension of those fibers can then allow for excessive motions in there, which then further breaks down the disc. That's why the combination between TL junction, understand what's going on the lumbar spine, hip, and looking at these rotary forces, even as we get into the pelvis and the innominates, it's very helpful. And I don't always, whenever I'm seeing a lower back or anything down there, it's always the unit I'm going through, because I'm wondering, how can I take stress off of it? If I'm getting these excessive forces in my lumbar spine patient, one of the fastest things I can do and best things can be if I can find a rotary dysfunction above or below it, where I can take the stress off the lumbar segment. And whether that's in a flexion extension moment and I can improve the mobility of the other joints, or definitely in rotation, even going down into supination, pronation of the foot, and how quickly alterations there will drive up into the lower back.
Yep. And we've had all kinds of talks about this, right, guys? And where it's just, and this is why we'll continue to spend time on the TL junction almost every day when we go through classes, just to say that we need to get this down, because these rotational forces, they will tear up the lumbar spine. And I mean, these are pretty substantial injuries. I think I've mentioned that I've dealt with these myself, where you'll get these kind of lateral shears going across that inner disc space, and you can develop, actual translational lesions of the lumbar spine, lateral translational lesions of the lumbar spine that are pretty, they're pretty debilitating when you have them. And they present a lot of times very similar to a disc lesion, but the difference is they don't have leg pain. But they do have pretty severe pain within the lumbar spine. So, and this is something we will go over, because we'll talk about basically how these things interconnect with TL junction, lumbar spine, pelvis during module 5 coming up here, and then we'll do even more of it in module 7.
So Eric, how do you see the biomechanics in the lateral translation lesion, as far as like the facet joints, disc position, relationship to the iliolumbar ligaments? Now I'm curious, what is your model on that?
So there's a couple of thoughts here. The one that I ascribe the most to is it's very typically going to be caused by a rotational loss. So, and then maybe that's the population that I see. I see a lot of young athletes. I see a lot of people that are runners. I see, so a lot of these things are more rotational based activities. But the idea is, for instance, if we have a patient that comes in, I ask them to do rotation to the right, and they're substantially limited, right? So we're looking at something 30% or more, probably suggests a TL junction lesion, right? TL junction restriction. What that should do is, with right rotation, we should have left translation of the thoracic segments, correct? Right. This is the biomechanical method that we've kind of established throughout the thoracic spine. If, however, we remove that ability, we take that thoracic spine and we stiffen that up, and now all of a sudden we can't get that rotation, we can't produce that translation, because the translation is really what produces that kind of natural scoliotic curve with rotational movements. All of that force is going to be translated back down into the lumbar spine, right? And so any vulnerable segment, any segment that has some sort of breakdown to it, and it has to be, you have to suspect at this point that it's going to already be somewhat unstable, because the thought process is, if I can't rotate right and I'm getting this translation left, right, where the segment will shift in that direction, then that segment already has to broken down enough to produce enough of a shift where it will fixate in that direction, right? The other possibility here, and this is the one that I think Jim champions a lot more than rotational problems, is leg length discrepancies, right? So a functional leg length increase on, say, the right side. So the right limb would be operating too long compared to the left. Now, this would occur with something like a lack of hip extension, lack of ankle dorsiflexion, maybe a lack of subtalar eversion, essentially something that's going to kind of push the leg up into the back. That could also cause that same contralateral translation of one of these segments. Now, you can develop these sort of pressures and not have it kind of slip and jam up. And that's usually the one that becomes very painful, is the one that actually subluxes into a lateral translation, particularly if it happens suddenly. The ones that I used to get personally were from playing hockey, going to swing the stick, coming into this sort of position for me, which actually equates to a right latexion moment. You could feel it right away. It would just bang, there it is. I knew, exactly when it happens. And it's not necessarily instantaneously painful, but within the next 12 hours, it will be quite painful because it'll jam into this position. Now, all of a sudden you have all of these structures, disc, ligament, articular facet, joint capsule, every structure that you have within that lumbar segment that's designed to help resist this sort of motion, all of a sudden is now stretched all to its limit and stuck there with all this pressure against it, essentially with no relief unless you can get that to reduce back in the other direction. And during the classes, we've talked about this when we've looked at some of the intersegmental stress tests for the lumbar spine, right? These are the ones that Jim doesn't necessarily teach much anymore. He doesn't necessarily see or doesn't necessarily agree with a lot of the same principles that I use them for, but some of the ones, in particular, the ones where we're looking at lateral shear, I still think is very useful because I think it's our best articular test, right? So it's our best biomechanical test to look for these translational lesions, and it's also a reasonable treatment for these sort of things.
How would this translation lesion or lateral shift appear on the biomechanical exam?
Well, so this is part of the problem with these things, is that they can be variable. Depending on what the person was doing when the translation occurred, or if the translation occurs as more of a cumulative sum problem, right? So if we have somebody that's a runner, and as they stride with their right foot, right, as their right foot's coming forward and they're swinging their left arm forward to counter that movement, it's just slowly rotating that segment and pushing that segment to the left, right? So that can happen as a cumulative sum. It may not be as painful, right? It may be less severe versus somebody that is playing softball and takes a swing and bang, there's the thing that happens, and that within the next 12 to 24 hours is going to become quite painful. So the two things that I will look for most substantially, almost as my, I guess you'd call it an illness script sort of marker. Number one is these patients will have a difficult time going from sitting to standing. They will have a real tough time getting their hips underneath them because the hip flexor, the psoas major hypertonicity that develops as a result of this thing is exquisitely bad. I mean, it's about as bad as it gets outside of having an acute disc herniation. So that will be one thing you can ask them that very specifically. When you go from sitting to standing, do you have a hard time feeling they can get your hips underneath you? Universally, they will have issues with that. The other one is looking at side bending of the spine, right? Because if I can't translate my, we'll get, like I said, we'll get into this more during the course, but L5 tends to be kind of immune to these issues because it's wedged in between the two ala of the pelvis, but L4 is above that, so it's usually the one that's causing these problems. If I can't translate to the right, I will have a difficult time side bending to the right as well. And then you can actually try a translational thing where you actually grasp the shoulder, grasp the pelvis, and you try and translate them across. Those two things will be substantially limited in both side bending and translation. And because the differential for this is typically going to be some sort of disc herniation, a disc herniation, as you try and correct that translation and standing, will be acutely painful. It will immediately reproduce pain. But if it's a translatory lesion, it won't reproduce pain. In fact, you're more likely to relieve pain by trying to produce that sort of motion than you would be to actually produce pain.
Are you seeing the psoas hypertonicity on the side to which it's translated to? So let's say if we're right rotated, left translated. Are you seeing that hypertonicity on that left side toward the translation where the psoas attaches, or on the opposite side?
Yeah, you'd suspect that you'd have it on the side that it's translated toward, but it will depend on what structure it is that actually becomes the painful structure. So if it's the disc, you could see it on both sides. If it's the facet joint unilaterally, it would be on the one side that's actually affected. So if we've translated left and we're getting impaction of the left facet joints together, then the left psoas would be the one that you'd expect to be hypertonic. If, however, we've translated left and it's more the traction on the right facet joint capsule, then you'd expect that tone to be changed on the right side. So again, you can't look at that as a diagnostic marker because it's so variable from one to the other. So essentially, you have to look at this from a perspective of they can be painful in both flexion and extension, or they could be painful in one or the other. It doesn't necessarily have to be both. But the biomechanically, looking at the side bending movement, looking at the translatory movement, and looking at their ability from going to sitting to standing, that's going to be the most distinguishing factor for me to differentiate this from the nearest differential diagnostic marker, which would be a disc herniation. Right. So when Jim was talking about this a couple of weeks ago, and he's talking about what's the differential here. It's like, well, it could be this or it could be that. That's the differential. Differentiate between these two potential pathologies. Because in most cases, a disc lesion is going to be more painful going from standing to sitting versus sitting to standing. Right. As you flex the spine, that's going to put more pressure on that disc, fire that thing, more pressure posteriorly either into the nerve or into the damaged tissue. And so that's going to make it worse going standing to sitting versus sitting to standing.
Yeah. And so your passive arthrokinematic tests would be somewhat variable. Is that correct?
Not necessarily. Actually, the biomechanical test is usually pretty straightforward. When I look at it and I say, okay, I can't lean right, I can't shift right, I'm going to lay them down on their right side, and I'm just going to take that segment and try and shift it. Again, this is why I think that lateral shear stress test is still a useful thing to teach from a hand placement position, from a pressure, the vectors and all those sort of things that you're trying to accomplish. So you just lay them flat on their side, loop through their arm, grasp onto L4. L4 would be the superior half, grasp onto L5 here, and you're just trying to push it back in the direction that it should be able to go. And there should be some give, right? You should have some movement. These ones that are fixated, that are real bad, you'll run into a hard block and it just won't budge. So when it comes down to it, it's usually pretty simple.
Yeah. So this is something that can go over a lot of the mechanics. If you're not quite getting this, from the conversation, it's fine. You're getting some hands-on when you get into a Saturday morning.
We'll go over it.
You'll go over it a bit and see it. But this is a nice one to kind of model to see it. And the 4-5 is always good too, because it's kind of the segment that counter rotates when you go into single leg stance. So it does some unique things, because L5S1 is a little bit more stable in that stance. But I can see where in standing, if you're going to stand on your left leg, you usually get a contralateral rotation toward the flexing hip of 4-5, which will give you that rotary moment.
I got to step out for a second. I got somebody.
Go for it. We'll switch gears a second here, because I want to go over, I'll send you those slides on flexion and extension, the biomechanics. But, with sacrum nutation, counternutation. So let's have a little fun here there. Tanner Newberger, I didn't pick on you last week at all. You alive in there?
I am.
Nice. How you doing?
Oh, not too bad.
Good. What do you know about nutation, counternutation?
Not enough.
Not enough. Yeah, it's tricky, and it's one of those things that can ignore. But you're gonna love this once you get into it, okay? Because what you're gonna do is you're gonna look at every lifting move that you do and think about after this Module 5 course, and you're gonna be wondering, where's my pelvis now? And it's what I look at in people who lift, and for failed load transfer is one of the key things. So you're gonna love this when you get into it. But some simple facts on this are, do you remember which position is closed pack position, or can you read? Oh, poor
Yeah, I
Tanner.
could see it there. That's the full that full nutation is the closed pack.
Yeah. So, that's a position of stability. So when nutation is when the sacrum, if you think of it just being rocked forward, where if you're sitting within the innominate, it's gliding forward, or simplistic terms, within the innominate. And that's considered, somewhat, if it's full at its end range, it's closed packed. But for most standing and loading activities, it's going to be in some level of nutation versus counternutation, which would be the closed packed position of that joint. So full nutation is one where if I'm in standing, it shouldn't always be in full nutation, closed pack. It should be a little bit in the mid-range, nutated, but not fully nutated. Those individuals which stand the sacrum in like a fully nutated position in the innominate creates a lot of stress on the ligaments and compression in the joint. So people who stand like that with it in the closed pack all the time will be prone to having a few more different pain syndromes that can occur. And the idea is that a good position is described that the sacrum should remain nutated when we're sitting and standing and loading the position. But again, that depends when the way you're sitting. People with a dysfunction where they may be sitting in a closed pack or counter-nutated on one side, you get increased stresses on the dorsal ligaments, interosseous ligaments, and the other stabilizing functions of that area. So that'll be one of the things that we'll kind of go over, is just to get a sense of, as I'm in a loading phase, and when we do our weight shifting tests, we're often looking at, in standing, is can I maintain this slightly nutated position of the weight bearing leg? Or if I get a counter nutation and a rotation in that leg, and we looked at this a little bit, I think briefly I looked at it in maybe some in module 1 and also a little bit in module 2. If you lose that control, it impacts everything through the pelvis and lumbar spine. So again, talking optimal posture, sacrum is slightly nutated. It's more suspended between the innominates. And this sacral rotation is relative to the innominates. It's that forward position. And again, this is restrained by the sacrotuberous ligament. So have you ever palpated someone and they have a very sore sacrotuberous ligament and they're irritable through there? Oftentimes what you'll also find is an irritated biceps femoris, because you have fibers of the biceps femoris blending up in most cases into sacrotuberous ligament. So somebody with a sacral dysfunction, oftentimes what you can find is a hypersensitive sacrotuberous ligament, but also a facilitated biceps femoris if you check them supine or standing. And if the innominate is unable to properly lock at that point, or you're able to get forced closure, if you ever test hamstring flexion strength, like in supine, and they can be they'll get non-fatiguing weakness. If you stabilize the SI joint and you improve that hamstring strength, they're having probably a forced closure issue or an issue stabilizing that, and they're probably stressing through sacrotuberous ligament. So if you see a sore sacrotuberous ligament, kind of turns you onto this track of looking for stability in this range or this region. Arthrokinematic glides, save that to the course. It's a hard thing to visualize in this joint, the way the glide goes. Again, just know that in here in your notes, it's inferior and posteriorly, and it's a small amount when you're talking about nutation. But again, that can twist your mind a little bit. So wait for the course on that one. I don't have a good video. Counter nutation of the sacrum. So palpating for counter nutation can happen one of two ways. You think the sacrum can rock backward on the innominate, or the innominate can go forward on the sacrum. So in some individuals, if you look at this in standing, you'll find that, when they go to stand and they go to transfer their weight to their right leg, you may feel the right anterior innominate go anterior, or you may feel the sacrum then push posterior. And that's that counter nutation. We noted in standing, in the loading leg, what they'll talk about, and the guys reading Diane Lee's book, is she'll talk about this as a failed load transfer, because you lose the ability to transfer load through this joint efficiently, and you have to find some way to make it up. So generally, you're not going to see this as a SI joint problem, though you may, but generally you're going to see this as an L5S1 or L5 or L4, L5 problem, and also potentially a hip problem, because this loss of control usually interplays with hip and lower extremity control, with forces driving from below. Again, we get into TL junction. If we have a TL junction lesion with a rotation and the upper thorax is rotated, it can create rotations in the pelvis and SI joint. So you will see those cases where this loss of pelvic control and this unlocking or failed load transfer through the SI joint occurs from a thoracic rotation. So that you'll look at more so in the later modules, probably a little bit in 6, 7, and a bit in 8. Yeah, the common one is the sitting position where, again, the person gets sitting pain and irritation along the long dorsal ligament. One thing you can think about is that they're losing pelvic control in sitting, and they could be in a counternutated rotation, and it's creating stress along those long dorsal ligaments. It's a common one you'll see, but because it's rotating back, you may also get a counter rotation of the lumbar spine. So my right sacrum is rotating posteriorly, so my lumbar spine can be rotating relatively to the left because the sacrum is in L5, maybe rotating to the right. So you get these rotations that can occur, driving forces up if you have this counternutated segment. And again, with some others and people have talked, Eric will talk about it too, is commonly what you may see is this one is you're going to see this long band of hypertonic muscle running from the sacrum and ilium up into the thoracic spine, because you're going to see the sacral multifidi are going to control this, the erector spinae are going to control this, and they're going to attach up to the transverse processes up in the upper thoracic spine and to like a posterior tubercle in the rib. So you'll see these functions emanating, or this hypertonicity going all the way up into the thoracic spine in these individuals. So again, in module 7, we'll look at these people who maybe have thoracic irritation that may be coming from the pelvis because of the unlocking or counternutated sacrum, or again, the same thing is if you have a rotated thoracic spine and now it's affecting force closure in the pelvis. It can play both ways, but I tend to think you tend to see pelvis maybe driving up a little bit more than the opposite. Second here. Again, talked a little bit about the different force couples. And I've shown a couple of people in labs where you can activate sacral multifidi, pelvic floor or piriformis, and stabilize the SI joint to create force closure. So that's how you can test form and force closure in these individuals where you feel like there may be an expanded neutral zone. So Eric, I've just been covering nutation, counternutation in the notes, and just load transfer concepts as we go through there. And then I was going to get into, since we have a little bit of time here, it's a hard time to rush this one, but I might save maybe torsions for the next one, because I think that'll be a bit confusing at first. But let's talk about basically a innominate motion during gait.
Okay.
Keep it simple there. There we go. So how would you describe, like the notes are up here, but kind of in your words, Eric, how would you describe, what's happening? Let's say on the right innominate first with right heel strike during gait.
Well, so basically what will happen is you'll get the tightening of the posterior hip capsule, posterior hip structures as the leg swings forward, right? And so what it'll do is it'll take the innominate and it will posteriorly rotate it relative to the sacrum, right? So relatively speaking, as we're posteriorly rotating that, and again, this goes into some of the sacral torsion stuff, but the tension on that's actually going to help us create a sacral torsion, which we'll talk more about, I guess, next week, and we'll definitely talk about it during the course.
Mm-hmm.
But that's what should be happening on the heel striking foot. So as the foot that's swinging forward, you should get a posterior rotation of the innominate.
Mm-hmm. Yeah, and then that occurs. You also have, we also talk about the pelvic rotation too. So in the transverse plane, you have the pelvis rotating to the left at this point. And again, what to talk about too is like we talk about things as Eric's talking about, as you're loading the leg too. It's though you get this rotation of the innominate. It's that idea that one of the models they say is that to some degree the with the innominates and the sacrum, it stays relatively nutated on both sides. It doesn't, there may be the one side's gonna be a little more counternutated than the other, but neither one is at its end range counternutation per se when in weight bearing. Is that a fair statement, Eric?
Yeah.
Mm-hmm. So, as we talk about this is, the pelvic girdle, a pelvic rotation. Hold on a second. So that's what we're talking about next is intrapelvic motion with right heel strike. So we have the right innominate with right heel strike be posteriorly rotated relative to the left innominate. The left innominate, again, because you're in end range extension at this point, to be anteriorly rotated relative to the left innominate. And again, the idea here, the simple version of this, not getting into torsions, is within this system right here, the sacrum, and just what Jim talked about his as an axis through the sacrum is right rotated between the nominates. But both the nominates in double weight bearing will be relatively nutated, not completely nutated. Though the one, in this case, the right one, right, Eric, would be more in the nutated position than the left, more closer to closed packed, I would say, as we load, and that creates that axis of motion on the right leg.
Yeah, I mean, technically that would be the case. The big difference here is the axis of the sacrum changes. It's not vertical. It's oblique, right? Yeah. So it's going basically from the PSIS across the ILA at these angles.
That's why I'll flesh that out next time, because it can really compares two models.
That's just what makes it difficult making that statement that the innominate is actually the right side sacrum would be more relatively nutated compared to the innominate, because essentially that axis of movement that you're going to produce pulls the sacrum sacral base posteriorly with it. So yeah, I mean, in theory, you want both sides to remain relatively nutated compared to where the innominate bones are, so that they're stable, right? Nutation is essentially the form closure position of the SI joint. So I'm not sure if you were covering that while I was gone or not, but the idea is that you get the actual articular stability of the joints being tighter together, right, and more capable of holding themselves together. So yes, that's what you're hoping for.
Yeah, and how with them to kind of be able to the hard part I think that they'll run into is they sort of rationalize, where Jim and some others will talk about the sacral position. They'll talk about the axis going right through the sacrum and the sacrum rotating more like this, which in essence is true. What Eric's going to get into is a little more interesting when we look at where, because of the pull of the ligaments and the tissues, there is a tilting mechanism as well. And that's that right on right, left on left axis. So like at this point here, before you get to the course, it's good to understand it as you look at gait and you get this innominate rotation and you get the pelvic rotation here for right heel strike, it's going to rotate to the left. They'll talk about the axis of rotation going through the sacrum and rotating to the left with that. And what Eric's going to layer onto that is that extra piece, which comes from the osteopaths, which is the rotation model of the sacrum within the innominates. But for right now, what I want you to just get a grasp on is what are the relative motions of these joints, as we're walking. So when you're looking at your patients and you watch your patient walk and you think, okay, I'm in right heel strike, you can take it as Jim says, I know my right innominate is extended, as Jim would call it, or posteriorly rotated, which are the same there. My left leg is back and it's anteriorly rotated, or
extended.
No, that's extended. I got it wrong. Again, the right one would be flexed. The left one would be extended. And again, in that position, you have a relative rotation plane of the pelvis to the left. So as you watch people walk over the next week, just in your mind, kind of try and go through, okay, here is at heel strike on the right, this is what I'm seeing. This is where the relative positions will be of these things. Both loaded, relatively nutated, but again, as you can see, because of the extended position, the flexed position on the right, you probably have more of a sacral nutation moment there to lock that right upper joint, which Eric will get into, will create a bit of that sacral torsion that's coming down the pipe later. But if you can, go ahead.
Essentially, what you guys have to remember about this is that the SI joint is actually more mobile when you are weight bearing, right? So when you're in swing phase of gait, so in this example here, as the right leg is swinging forward, the right innominate, or the right sacroiliac joint, I should say, is going to be less mobile than the left one. The left sacroiliac joint is going to have more mobility with it because it's weight bearing. The idea being, you have your innominate and you have your sacral surfaces, and there's this fibrocartilaginous pad in between. So when your weight is on top of that, it compresses that pad and allows for more movement through there. So this is part of the reason that things actually will start to change when you heel strike, right? As you transfer weight from the left foot onto the right foot, you'll start to notice that there'll be differences between which joint is actually producing movement compared to the other. So it's tough to make the definition by saying like, well, if I have the right innominate posteriorly rotating as I swing the hip into flexion, and the left side is anteriorly rotating as my hip moves into extension. Because what we're saying here is that the idea is that this is left rotated in the transverse plane. But when you're thinking about it, it's actually got your pelvis facing to the right, right? So actually your pelvis is actually going to be facing the right side, even though it's rotating in that direction. We're looking at it from this direction coming from above. So some of these terminologies will be confusing because some of them are osteopathic models and some of them are just pure biomechanical models. So I think Jim, when he and I talked about it, we were just going to do anatomical stuff and not worry too much about the osteopathic components of it. So we'll clean this up before we get to class so that it's going to make sense when we actually discuss how we use it for examination and treatment.
Yeah, so I'll put these notes out here because this is just the base package as you get into it. And the next page on this has the sacral torsion models and notes. But again, that's one of those ones where you can kind of decide, Eric, whether, okay, is that better just to go over in person because you can play with it and feel it in movement versus that's something that's really beneficial to discuss in this setting.
Yeah. I mean, it's essentially something that you almost have to make like a model for. Like you have to take a piece of paper, cut it into the shape of the sacrum and, produce the axes so you can actually spin it around those things. It's sometimes it's tough to see. The actual mechanism, I think it's still a useful thing to learn because it's the exact mechanism that occurs when you're walking.
Yeah.
And so when we're talking about things like how do these latection moments and all these sort of forces transfer from the foot, right? These ground reaction forces transfer from the foot, go up the leg, and then traverse the pelvis to get into the lumbar spine and into the PL junction. You have to know how this works. Because essentially, if we're finding dysfunction there, it's really going to be a big problem with how we're able to attenuate these loads without setting something off or causing additional problems. Yeah. It's tough to do over Zoom, I guess is the point.
Yeah. But probably what I do is basically put it on tape too, so that, okay, after the course, at some other point, you can kind of come back to this and get a sense of, okay, look at the notes, be able to see it discussed so you can kind of be a little more, jar your memory. But early on, once you get in the mindset of thinking as you walk, just pay attention to, okay, what's my patient doing? If I know that, if I can time it, I know what's going on right heel strike, mid swing to left heel strike, you can kind of get a sense of what are the relative motions. And if you're familiar with them pre-lab, then you're doing great. And just get a sense of that. So if you can just pull these portions of it out, then it's gonna be really easy to pick up, why do I have a lesion with this portion of the gait? And then you can layer on the rotation and the torsion moments that may occur. So this is a really good starting point for that section. Again, what we covered today was basically the biomechanics that you'll be doing on Saturday in the morning and then Sunday in the morning. And they'll go into a little more depth. Of course, in the course, it'll be a little more functional. But we wanted to kind of introduce the concepts, put something on tape for you so that, you have something that kind of matches what you'll be seeing in the course.
Yeah. And we'll probably have, I don't know if maybe we'll have Matt do it when I get to Chicago or something like that. We'll have him probably videotape my explanation of the sacral torsions and some of these things here with Gait, because that way we can post that sort of thing that you can go back and reference.
And I mean, I'm going to upload the videos from the last course. Matt had to send them to me on a flash drive, and I finished uploading them and kind of editing them and posting them and putting them up. I will put them probably in, like I did the lab book with the videos of the skills. I will post them in probably a separate book right underneath of that, so they don't get lost in the other skills book. I'll label it, Chicago 22, and that way if you want to go back over the course videos that Eric did in those things, I think there's good sections of them. You'll be able to go over those course videos, and it's quite a big section.
Yeah, there'll be a lot.
But if Matt's not back, one of the guys from here may come out. So we'll find somewhere, or I'll find somebody who's willing to videotape the courses out there. Do it.